The House Health Policy Committee will come to order. Would the clerk please take the attendance?
Chair Rogers.
Yes, here.
Representatives Whitsett. Here. Carter.
Rep. Carter? She's here.
Hadsma.
Present.
Neely. Here. Glanville.
Present.
Kafia.
Here.
Conlon.
Present.
Farhat.
Here.
Fitzgerald.
Here.
Miller. Here. Rangan. Here. Vanderwall.
Present.
Filler. Mueller.
Here.
Van Workum.
Here.
Roth.
Here.
Schmaltz. Thompson. Yes. Madam Chair, you have 19 members present. You do have a quorum.
Thank you. Representative Farhat moves to approve the minutes from our meeting on May 16, 2024. Seeing no objection, minutes are approved. I would like to take Chair's point of privilege to recognize my Youth Advisory Council. So thank you for being here from Kalamazoo to observe some democracy. Prior to testimony and votes, if you wish to speak or express your position on legislation before us today, please submit a card to the clerk. Sergeants in the room will be happy to collect the cards and get them to the committee clerk on your behalf. In the interest of time, if you are welcome to submit written comments to be submitted to the bill record. Today, we will first vote on House Bills 5043 and 5044, which revise the process for certifying death records in Michigan. We heard testimony on these bills at our last committee meeting on May 16. We will then hear a brief overview from Representative Brabeck on House Bill 5114, which aligns Michigan's mental health code with the public health code by recognizing additional clinicians in the MHC. We will proceed to adopt the H3 substitute and report the bill. After we report House Bill 5114, we will hear additional testimony on House Bills 4890 and 5519, which would create the opportunity for the state of Michigan to partner with a private sector entity to manufacture insulin in a new facility in our state. We took initial testimony on these bills at our hearing way back in February, 28th to be exact. There are substitutes that Representative Vanderwall and Conlon will speak to prior to adopting them and reporting them from committee. And last up on the agenda for today, we will be taking testimony on House Bills 5283 and 5284, sponsored by myself and Representative Vanderwall. It's a busy day for Representative Vanderwall. These bills would facilitate the creation of a health data utility in Michigan. First, we will vote on House Bills 5043 and 5044, sponsored by myself and Representative Mueller. Are there cards to read in? There are cards to read in. Michigan College of Emergency Physicians, supporting both 5043 and 5044, and a card of support from Service Corps International. Representative Fitzgerald moves to report House Bill 5043 with recommendation. Madam Clerk, please take the vote.
Chair Rogers.
Yes.
Representatives Whitsett.
Yes.
Carter.
Yes.
Hadsma.
Yes.
Neely.
Yes.
Glanville.
Yes.
Kafia.
Yes.
Conlon.
Yes.
Farhat.
Yes.
Fitzgerald.
Yes.
Miller.
Yes.
Rangan.
Yes.
Vanderwall.
Yes.
Filler.
Yes.
Mueller.
Yes.
Van Workum.
Yes.
Roth.
Yes.
Schmaltz.
Yes.
Thompson.
Yes.
Madam Chair, you have 19 yeas, 0 nays, and 0 pass. The motion prevails.
Representative Filler moves to report House Bill 5044 with recommendation. Madam Clerk, please take the vote.
Chair Rogers.
Yes.
Representatives Whitsett.
Yes.
Carter.
Yes.
Hadsma.
Yes.
Neely.
Yes.
Glanville.
Yes.
Kafia.
Yes.
Conlon.
Yes.
Farhat.
Yes.
Fitzgerald.
Yes.
Miller.
Yes.
Rangan.
Yes.
Vanderwall.
Yes.
Filler.
Yes.
Mueller.
Yes.
Van Workum.
Yes.
Roth.
Yes.
Schmaltz.
Yes.
Thompson.
Yes.
Madam Chair, you have 19 yeas, 0 nays, and 0 pass. The motion prevails.
Next up is House Bill 5114, sponsored by Representative Reingans. Representative Brabeck will provide her report on the legislation that had been sent to her subcommittee on behavioral health, which took testimony on it earlier this year, and then we will adopt the H3. Welcome, Representative Brabeck.
Hi, Chair, members of the committee. Thanks so much for allowing me to be here with you today. I apologize for my voice. As you all know, and we've talked about several times, we are in the midst of a mental health crisis that was only exacerbated by COVID. Here are some of the numbers related to that. 4.2 million Michiganders live in places in our state that have mental health care provider shortages. 38% of Michiganders with with mental illness have unmet treatment needs. 38%. And a whopping 72% of Michiganders have unmet substance use treatment needs. Again, all exacerbated with COVID. 5114 is a piece of the puzzle that we need to help in terms of the solution. I know you've heard me talk before about how we're putting together this puzzle in terms of mental health coverage. This is another vital piece in that puzzle. The bill would help address the provider shortage by amending the mental health code to add physician assistants, associates, nurse practitioners, and clinical nurse specialists to the definition of a mental health professional. This will allow PAs, NPs, CNSs to use their education and training that they receive to help meet Michiganders' growing needs, but in medical settings. As it stands, PAs, nurse practitioners, and clinical nurse specialists are all educated and trained to deliver mental health care. However, because they are not currently recognized under our state's legal definition of mental health professionals, they are unable to provide all aspects of needed behavioral health care for which they are trained. Patients in distress may see PAs, NPs, or CNSs in an emergency room, in an inpatient psychiatric facility, or in an outpatient mental health clinic, all places where all of these practitioners already work. In some situations, these practitioners are prohibited from administering mental health care that they have already been trained in how to provide and know how to provide, forcing struggling Michiganders to continue to languish until they can see someone who is currently classified technically as a mental health care provider. Here's some of the stakeholder work that's happened. So after 5114 had a hearing in our Behavioral Health Committee, some of our groups who really focus on lifting up autism work and working with folks who are on the spectrum reached out to both myself and to Rep. Reingen's office with concerns that by classifying more folks as mental health care providers, that there could potentially be an increase in children who are on the spectrum and for people who are on the spectrum and folks who of color, and the increase in restraints and seclusion. So the fear is that with more providers in the field, that more restraint and seclusion incidents will occur, and data suggests that children on the spectrum and people of color are more likely than their neurotypical or white counterparts to be put into restraints or secluded. So Rep. Greingens heard that, and to that end, she convened 4 work group meetings that brought together people from the disability and autism communities, patient advocates, providers, MDHHS, Blue Cross Blue Shield, the health plans, CMHA, MHA, and others to discuss these reforms, the reforms that can be made to be able to address the seclusion and restraint processes in order to ensure that the most vulnerable among us are not disproportionately subjected to these practices. The work group ended by discussing recommendations for potential regulatory changes that are Michigan-specific and using Michigan-specific research, but found that additional bills are likely to be needed and can be introduced later in the term. Rep. Reingens is working with both the Disability and Autism Legislative Caucuses to ensure these next steps. You also have a substitute in front of you. The substitute makes some minor language changes that were requested by Lara, and it brings this bill into alignment with other statutes. Here's an example. It changes every instance of clinical nurse specialist certified to clinical nurse specialists, and every instance of physician assistant to physician's assistant. So those are just some examples for you. I do want to let you know that Rep. Reingen's office is continuing to work with stakeholders around training and experience language before a floor vote on 5114. Thank you, Madam Chair.
Thank you, Chair Braybeck. I think we see Representative Farhat has a question.
Yes, thank you, Chair, and thank you, Dr. Braybeck.
Sure.
I think it was really helpful to hear you report out on this bill and the progress that was made on it in the subcommittee. I guess my concern kind of goes back to that point you made, and it's not so much as a concern, more as maybe a general critique of our public health code when it comes to restraint usage with individuals with disability. Is that an area that you foresee some work coming down the pipeline on, where we can kind of streamline this and make it so that, any medical professional,
Sure.
not exclusive to their
Sure.
licensure,
That's right.
doesn't use practices that don't have the patient's best interest, or maybe are very arcane in some ways. Can you speak to that at all?
Sure. So it's interesting. I mean, looking at whether it's the health code or the mental health code, there's some work that can be done, right? And I know that Rep. Ryan Gins is continuing to do that with respect to that. So I think the broad stroke answer is yes. The specific fixes are going to be forthcoming.
And that's very helpful to know, especially considering. So I appreciate the
Yeah, no
diligence of the
problem.
subcommittee, and I appreciate the sponsors' work on this as well.
Thank you. Seeing no other questions, we're going to read in the cards. Michigan Association of Health Plans supports 5114. MSMS opposes the bill. Michigan Psychiatric Society opposes the bill. Michigan Health and Hospital Association supports the bill. Lincoln Behavioral Health supports the bill. Daniel Sharon, Michigan Behavioral Health and Wellness Collection supports the bill. Detroit Community Health Connection supports the bill. Central City Health in Detroit supports the bill. Michigan Side Community Health Network Detroit supports the bill. The Guidance Center supports the bill. CNS Healthcare supports the bill. Detroit Common Health Connection supports the bill. Oakland Community Health Network supports the bill. Michigan Mental Wellness supports the bill. Common Ground supports the bill. Michigan Primary Care Association supports the bill. Michigan Council of Nurse Practitioners supports the bill. Michigan Osteopathic Association supports the bill. Nolan Harrington D.O. opposes the bill. Scott Monteith, physician, opposes the bill. Dr. Eric Ashtice from WMed is an opposition of the bill. Dr. Soleil opposes the bill. Howard Friedman opposes the bill. Dr. Meeland opposes the bill. Anthony Leo opposes the bill. And Dr. Asan opposes the bill, as well as Dr. Poznansky opposes the bill. Representative Glanville moves to adopt the H3 substitute on House Bill 5114. Madam Clerk, please take the vote.
Chair Rogers.
Yes.
Representatives Witsit.
Yes.
Carter.
Yes.
Hadsma.
Yes.
Neely.
Yes.
Glanville.
Yes.
Kafia.
Yes.
Conlon.
Yes.
Farhat.
Yes.
Fitzgerald.
Yes.
Miller. Yes. Reingens.
Yes.
Vanderwall.
Pass.
Filler.
Pass.
Mueller.
Pass.
Van Workum.
Pass.
Roth.
Pass.
Schmaltz.
Yes.
Thompson.
Pass.
Madam Chair, you have 12 yeas, 0 nays, 7 pass. The substitute is adopted.
Representative Glanville moves to report House Bill 5114 with recommendation as substitute H3. Madam Clerk, please take the vote.
Chair Rogers.
Yes.
Representatives Witsit.
Pass.
Carter.
Yes.
Hadsma.
Yes.
Neely.
Yes.
Glanville.
Yes.
Kafia.
Yes.
Conlon.
Yes.
Farhat.
Yes.
Fitzgerald.
Pass.
Miller.
Pass.
Reingens.
Yes.
Go call the chair. Health policy will come back to order. Clerk will please resume the vote.
Representatives Vanderwall,
Yes.
Filler,
Pass.
Mueller,
Pass.
Van Workum,
Pass.
Roth,
Pass.
Schmaltz, Thompson. Pass. Madam Chair, you have 10 yeas, 0 nays, 9 pass. House Bill 5114 is reported with recommendation as substitute H3.
Next up on the agenda are House Bills 4890 and 5519, which would create the opportunity for the state of Michigan to partner with a private sector entity to manufacture insulin in a new facility in our state. There are substitutes that Representative Vanderwall and Conlon will speak to prior to adopting them, and then we will report the bills. Representative Vanderwall and Conlon, please make your way to the front tables, and the floor is yours.
Madam Chair.
Begin whenever you're ready.
Thank you, Madam Chair. And give me a second to get my glasses on, otherwise even big print doesn't work. Good afternoon, Madam Chair and committee. As we already discussed, we have an opportunity here in the state of Michigan to really push us forward in the nation and help those that have been struggling with insulin. So you've already heard testimony on these bills. I want to highlight some of the changes that have been made over the past few weeks and months. Since February, there's been a lot of ongoing conversations about how to realize this dream, providing the truly affordable insulin to anyone who lives in this state, and how we can potentially bring manufacturing right here to our home state. Throughout these conversations, we have tweaked the language to address some of the liability concerns. This would include eliminating the requirement that the state own the manufacturing facility, changing the language about state of Michigan label, and eliminating sections that would have caused Michigan to become a purchaser or distributor throughout this process. This legislation not only emphasizes the need for affordable insulin that is available to everyone, but it empowers us to find creative solutions by partnering with the private sector. I look forward to continuing these conversations in order to get this across the finish line and make sure that we as a state lead this nation to make people healthier, better, and live longer. Thank you again, and I look forward to answering any questions.
We're gonna finish with Rep. Conlon in a second, and then we'll take questions. Rep. Filler.
Good afternoon, Chair Rogers and members of the committee. I'd like to first speak to the H1 substitute for House Bill 5519. The change you see is quite simple. The bill will no longer be tie-barred to a request that was never introduced. Aside from this change, it is important to again stress the significance of this bill package. We have been working hard with MEDC on the final language and will continue to do so to ensure that the insulin manufacturing program is as effective as possible. Finding a solution will mean bringing dozens of high-paying jobs to Michigan and providing an increased capacity for the production of generic insulin, which could be offered to patients at a low cost. Other states are interested in this concept, and Michigan is well positioned to lead the nation in providing affordable insulin to Michiganders. Let's not forget that diabetes is a significant public health challenge. It impacts just under 1 million Michigan residents. Many more likely have diabetes but have not yet been diagnosed. It is crucial that individuals have access to a reasonably priced treatment to keep their blood sugar levels under control. This is an issue I care deeply about. I have been tackling the topic of insulin affordability now for a year and a half. I urge members to consider the work that we have put forth, which can help make our state a healthier place to live. Thank you.
Go at ease, call the chair. Committee will go back. Hi, committee is joining. Representative Filler. It's been a long committee already.
So I guess one of my concerns with the bill package the first time it came up is that there was testimony that we don't have an insulin shortage, but we're now going to create sort of government-owned insulin to, I guess, maybe compete with private. So I assume your substitute maybe went to the heart of that a little bit. Is that what I'm reading at the sub? I still don't think I'm going to support the bill, but I assume that's what you're trying to do here.
Thank you, Representative. I appreciate the opportunity to address that. Yes, by what we've done is we've basically allowed the state to open the doors and to have conversation if it's working with a private sector insulin producer to bring them in to the home country. Let's put it that way. That's an option, but also the other option is to make sure that we can negotiate with those same folks and bring their product that's on the market here to the state of Michigan under certain things. We can work that out through contract to provide a very low cost, safe insulin to better the citizens here in the state.
Any other Representative Farhat?
Yes, ma'am. Thank you, Chair. Thank you to Representative Vanderwall and Representative Conlon for bringing this before us today. I just was wondering, in your research on this, I think it's really important, and you hit on something here, bringing drug manufacturing to Michigan, which I think is really important. We have really good life science universities, really good research places. I think it's a good synergy to have here is a drug manufacturing presence in our state or expanding that presence. Is there any things that we've seen from California and what they've done that we're maybe improving on or avoiding the pitfalls of what California has maybe done in some way that I think, because I'm a big supporter of this actually. I like this idea a lot and I like bringing manufacturing. But I'm just curious as to the feasibility and how we've looked at other states.
Well, yeah, you know what, Rep, I appreciate the question, and you know what, number one, we do understand that, you know, in conjunction of us working together, we want to, the ultimate goal is to bring a low cost. We've seen that California has spent millions and millions of dollars and they've really not been able to succeed. We're learning every day, and that this bill is going to allow us to move forward, to explore, learn from those lessons, but really capitalize on opportunity to negotiate through and provide a product that needs to be in human bodies so that they can have a long-lasting, healthy life.
Yeah. I appreciate that, Representative, and also everything is more expensive in California, that's for sure. It's one of the most attractive things to move into Michigan is an affordable lifestyle, so I appreciate it. Thank you.
Says the
I
population.
would just add that it is exploring, we're putting, in this legislation that allows us to explore and figure out the best way we could do it in our state. So we can learn from other states. So it has time.
Yeah, thank you.
Representative Glanville.
No question.
Oh, sorry. Representative Carter.
Thank you, Madam Chair, and thank you, Rep. Conlon, Rep. Vanderwall. Which one? I got it right? Okay. And I mentioned this earlier with testimony on these bills and anything that has to do with insulin. If you live in communities like ours, it's not unusual to see amputees or people who are blind simply because they couldn't afford insulin. And everybody knows that insulin, like EpiPens, everything is just skyrocketing. So any initiative that will lower costs and make the insulin more affordable for every Michigander, especially those who are economically challenged, is definitely appreciated. Now, my question to you is: if this is successful and we have a manufacturing site here in Michigan, what is the plan to distribute those sorely needed drugs in communities that are under-resourced?
There's a lot to that question. We will work with the folks that bring the product here to make sure it's distributed throughout the state, just like we did any other vaccine that we have or any other drug that we have. I believe wholeheartedly we need to bring it into the areas that have folks that are less fortunate. We need to make it very accessible. We need to make it easy to receive that product and afford that product. So we'll work very hard in conjunction with the departments to make sure that those areas are taken care of.
Follow up, just a quick follow up. Thank you. Just this past weekend in Pontiac, we watched one of our community leaders go into a diabetic incident where at this community center, they had been of accessibility to something he could use, a great thing for him that he did survive it, but yet and still the accessibility in communities that are underserved is very, very rare. That's where you see all your amputees at.
Yeah, thank you for that, Rep. Carter, because you're not wrong. The health outcomes that come from people rationing their insulin or not having the access they need is what leads to these problems and puts so much more kind of problems for our hospitals that are trying to deal with all these health outcomes. So this is, it just catapults into other things. So if we can take care of our diabetic population, like I said, 1 million of them, think of how that would help our healthcare system too.
Thank you. All right. If you would like to both make your way back up here for voting purposes. Representative, yes, I do want to read them the cards. Thank you. That's why my clerk is my right hand. So supporting 4890 and 5519, Michigan Association of Health Plans. Supporting 5519, Authority Health. Also support... supporting 4890, Blue Cross Blue Shield, supporting 4890 and 5519, Michigan Nurses Association, and supporting 4890, Authority Health, as well as Pharmaceutical Research and Manufacturers opposing the bill as written. Representative Roth moves to adopt the H2 substitute to HB 4890. Madam Clerk, please take the vote.
Chair Rogers.
Yes.
Representatives Witset,
Yes.
Carter,
Yes.
Hadsma,
Yes.
Neely,
Yes.
Glanville,
Yes.
Cuffia,
Yes.
Conlon,
Yes.
Farhat,
Yes.
Fitzgerald,
Yes.
Miller,
Yes.
Reingans,
Yes.
Vanderwall,
Yes.
Filler,
Pass.
Mueller,
Pass.
Van Workum,
Pass.
Roth,
Yes.
Schmaltz,
Yes.
Thompson.
Pass.
Madam Chair, you have 15 yeas, 0 nays, 4 pass. The substitute is adopted.
Representative Roth moves to report HB 4890 with recommendation as substitute H2. Madam Clerk, please take the vote.
Chair Rogers.
Yes.
Representatives Witset,
Yes.
Carter,
Yes.
Hadsma,
Yes.
Neely,
Yes.
Glanville,
Yes.
Cuffia,
Yes.
Conlon,
Yes.
Farhat,
Yes.
Fitzgerald,
Yes.
Miller,
Yes.
Reingans,
Yes.
Vanderwall,
Yes.
Filler,
No.
Mueller,
Pass.
Van Workum,
No.
Roth,
Yes.
Schmaltz,
Yes.
yes? Thompson.
Pass.
Madam Chair, you have 15 yeas, 2 nays, 2 pass. House Bill 4890 is reported with recommendation. As substitute, H2.
Go ahead, East, call the chair. Health policy will come back to order. Representative Carter moves to Representative Carter moves to adopt the H1 sub to HB 5519. Madam Clerk, please take the vote.
Chair Rogers.
Yes.
Representatives Witset,
Yes.
Carter,
Yes.
Hadsma,
Yes.
Neely,
Yes.
Glanville,
Yes.
Cuffia,
Yes.
Conlon,
Yes.
Farhat,
Yes.
Fitzgerald,
Yes.
Miller,
Yes.
Reingans,
Yes.
Vanderwall.
Yes.
Filler.
Pass.
Mueller.
Pass.
Van Workum.
Pass.
Roth.
Yes.
Schmaltz.
Yes.
Thompson.
Pass.
Madam Chair, you have 15 yeas, 0 nays, and 4 pass. House Bill 5519, the substitute is adopted.
Representative Carter moves to report House Bill 5519 with recommendation as substitute H1. Madam Clerk, please take the vote.
Chair Rogers.
Yes.
Representatives Woodsett.
Yes.
Carter.
Yes.
Headsma.
Yes.
Neely.
Yes.
Glanville.
Yes.
Cuffia.
Yes.
Conlon.
Yes.
Farhat.
Yes.
Fitzgerald.
Yes.
Miller.
Yes.
Reingens.
Yes.
Vanderwall.
Yes.
Filler.
Nope.
Mueller.
Pass.
Van Workum.
No.
Roth.
Yes.
Schmaltz.
Yes.
Pass.
Yes.
Thompson.
Pass.
Madam Chair, you have 15 yeas, 2 nays, 2 pass. The motion prevails.
Last on the agenda today are House Bills 5283 and 5284, sponsored by myself and Senator Representative Vanderwall. These bills create a health data utility in Michigan and establish a long-term funding source without impacting the state's general fund. We will also hear testimony from several members of the Michigan Health Information Network MyHIN team, including Dr. Isabel Pacheco, Chief Administrative Officer, Kim Batchelder, Director of State Accounts, and Marty Woodruff, Chief Commercial Officer. Lastly, we will hear from Dr. Kevin Bonsack with Trinity Health. Respectfully, I'm asking members to hold all your questions until we've completed all the testimony because your question may be answered by one of the technical experts. The committee will stand at ease. Call of the chair.
The committee will come to order. Representative Rogers and Vanderwall, the floor is yours.
Thank you, Vice Chair Whitsett and members of the committee. My name is Julie Rogers, and today Minority Vice Chair Kurt Vanderwall and I are here to testify on our health data utility bills, HB 5283 and 84, which would create a Michigan health data utility to combine, enhance, and exchange electronic health data for various healthcare purposes, including treatment, coordination, quality improvement, and public health. I have the policy bill, and Representative Vanderwall will show us the money. In 2006, the Health Information Technology Commission, or HIT Commission, was established with DHHS to promote the design and implementation of an interoperable healthcare infrastructure in Michigan. Interestingly, at that time, a position was created at the federal level to implement a strategic plan nationwide for the sharing of health information. Michigan Health Information Network, or MyHIN, is a public-private nonprofit collaboration dedicated to improving the healthcare experience and improving quality. Moving beyond a simple health information exchange model as currently operated by MyHIN and implementing an HDU provides the opportunity to modernize Michigan's public health data collection and ensure nearly instant and secure medical record sharing with healthcare providers. My bill, House Bill 5283, provides an updated definition of health data utility, which means a system that is operated by the Health Information Exchange that facilitates the exchange of health data, creates a unified health record for healthcare patients, allows for the exchange of information using multiple modalities, including query searches, and increases connections between health entities and social care services. Most of us have experienced a family member or found ourselves in situations where our medical team is flying blindly without a full picture of our medical history, including what medications we are all on, allergies we may have, and surgical procedures in our history. Often, medical decisions are made based on limited information that can have literally life and death consequences. These bills strengthen the existing framework that has already been established in Michigan under MyHIN and are a significant step forward in ensuring comprehensive health data is shared seamlessly no matter the healthcare setting so that the whole person can be evaluated and treated in a comprehensive, individualized manner. By synthesizing and sharing this data through an HDU, Michigan will drive down costs as healthcare providers will order fewer duplicative tests, improve health outcomes, reinforce the whole person care model of medicine, and strengthen coordination between various healthcare providers and settings. I want to take a moment to share a personal story from one of my family members. This individual has experienced multiple neurological symptoms over the last several years, including balance impairments and tremors, which eventually required placement in an assisted living facility for their safety. About a year ago, this family member developed a fever, which turned into pneumonia and required transfer to a hospital setting. As we checked in on them daily, remotely, I started getting nervous, as each day that an older person spends in a hospital, oftentimes the more complications that can be experienced. At one point during one of our calls, it was relayed that he was unable to get out of bed. When we questioned why, because this was puzzling to my husband and I, who are both physical therapists, we were told that virtually overnight he became a maximum assist of 2 people. That is, it was requiring 2 trained healthcare providers to mobilize him in a very difficult fashion because it was too difficult for him to get out of bed. For a week, 7 days of immobility. We later received a frantic call from his wife when she went to undress him when he was back at his assisted living to put on his pajamas for bed, and she discovered he had acquired multiple bed sores and deep pressure wounds around his buttocks and feet. My husband dropped everything, got on a plane, and flew to care for a family member. I eventually also flew down so that we could sleep in shifts and help care for him and turn him or mobilize him every 2 hours for his wounds to heal. We eventually asked for the hospital medical records and compared them to the paperwork on file at the assisted living. What we discovered while we were playing detective was heartbreaking. Just one of his medications, Cinemet or levodopa, had been accidentally left off the medication list that was sent from the assisted living to the facility to the hospital. This medication helps with Parkinsonian-like symptoms by reducing tremors and improving movement and function. It's kind of important. I can't help but think how those bed sores could have likely been prevented had he had the correct medications and the correct data had been shared. If this medical record could have been shared by his prescribing physician, many of his complications probably could have been avoided. Maryland and Missouri passed HDUL legislation in 2022, and since then, 8 other states, including Michigan, have introduced similar legislation. Think of it as a pipeline or an on-demand data highway where the health information can flow upon request for those medical providers who need it best to care for the whole person. Thank you, and we have Representative Vanderwall joining me, and MyHIN will be testifying for a lot of the technical details of this project.
Thank you, Chair Rogers, and the committee, Chair. Thank you for allowing me to speak and participate in this. But the bills before you today place Michigan at a cutting edge of data integration and improve health outcomes at the same time. You will hear from the you will hear from the experts the importance of moving this health data utility model. In conjunction with Rep. Rogers' bill, my bill will ensure the model is properly funded, with $6 million to be allocated the first year, $7 million the second year, $8 million the third year. Well, that's where it will stay and be capped. This funding model recognizes the process of implementing the plan statewide and recognizes the cost increases as it becomes widespread. The capabilities of this plan include data sharing, utilization, analysis. It'll help us prepare for the future and further sharpen our healthcare system. This is common sense legislation and will strengthen our system. I look forward to working with you to make this accessible throughout the state of Michigan. Again, pushing Michigan to be a leader in better health outcomes and better results for the patients we all deserve when we go to the hospital or to our doctor. Thank you, and I'm happy to answer any questions.
Thank you for your testimony. The committee will stand at ease.
Committee will come back to order. Next up, we have 3 individuals from MyHIN providing the testimony in support of these bills. Chief Administrative Officer Dr. Isabella Pacheco, who I think is on. Who do you want? Who would you like? Would you like to start and then have our Zoom guest, or who would like to start first? Okay. Welcome to Health Policy, and begin whenever you're ready.
Thank you. You have the handout in front of you, the deck. Thank you, Madam Chair and members of the committee. Special thank you to Representative Rogers and Representative Vanderwall for your hard work and commitment to making this go forward. So I'm going to start with a quick little overview of where we were, where we're at. First of all, I know some of you we've met with, some of you we haven't, so if it's repetitive to those we've met with, I apologize in advance, but I just want to make sure we get a good level set. So MyHIN was established under the Granholm administration. We have had support, ongoing support through the administrations. An important key takeaway is our first use case, as Representative Rogers mentioned, was part of the public health piece, was the submission of immunizations. That was key because it was to feed the MDHHS registry for immunization data. But what it also allowed for was the beginning of the foundation for what we refer to as the legal and technical infrastructure to support statewide data exchange, which we still use currently today. That's been in place for approximately 12 years now. When we think about MyHIN, we need to make sure that we remember a couple of pieces. We are the plumbing. That's the easiest way to think of us. We are the plumbing. Infrastructure is what we are technically, not very glamorous or exciting, but we are the plumbing. We're agnostic to all of the fixtures on the ends. That means the faucets. We don't really care about the faucets. We are the plumbing. That's how the data is able to move seamlessly and with ease throughout the state. So as the data flows to the state, it needs to be coupled with a legal chain. That legal chain is important because everybody in this state needs to know that that data and that plumbing is protected legally. Nobody gets to share data if they're not within the legal chain. Everybody agrees to the same terms to the legal chain. It's key to making it successful, just as powerful as the technical. When you think about that, that legal chain has to ensure that HIPAA and all of the regulatory agency requirements are met. The data flow, the legal chain, are what we refer to as infrastructure within the state that is already in place, that we already use today to move many data feeds through the system. So when we think about MyHIN's creation, right, and that piece of history, it then becomes a network of networks. So the support that you end up with and the strength that you end up with technically and legally is that network of networks. And that the slide in front of you that's labeled network of networks is a really good illustration of that. And it's all based on use cases which are part of that legal infrastructure.
I'm going to pause you just a second because we don't have the slides on the screen.
Oh. Sorry about that.
Does everyone have these at their places? Okay, go ahead. Thank you.
No worries. No worries. Before MyHIN, the slide that you see that looks like a whole bunch of circles with a whole bunch of arrows and dots and directions flowing everywhere, that is the burden that we had placed on data sharing. With MyHIN, again, the infrastructure that is in place has allowed us to streamline many of those. So it's just a one-to-one now. When you look at now, you'll see that data comes in, data goes out, and it goes seamlessly. consistently, equally, always. And again, requires three things: connecting to MyHIN, signing the legal, and identifying that you have a right as a trusted data sharing organization to participate in MyHIN. And it's there's a scrutiny placed on that so that just not anyone can. The network is growing on a regular basis now. When we go to, God, excuse me, sorry. When we go to the future and when we think what's next and why the health data utility is important, we have to think about all of the pieces that we've missed. Like, we have looked at health care, traditional health care data. All of us have other components to our lives that go above and beyond just health care. I think in this story that Rep. Rogers shared with us, we can look to that skilled nursing facility. Not many of us think of those as health care centers, just it's a place that you move to after a hospital before you go home. Physical therapists, I believe she referenced that. Those are all part of that journey, but all of that data doesn't always get shared for us as individuals. So as we go forward, Kim will take us through the future and where we need to go. Thank you.
Thank you, Marty. So if you want to follow along, I'm on slide 9. It's called The Future, and it's a picture, it's a circle diagram. But this represents a good graphic of what we envision the health data utility to be. The health data utility model, or HDU, represents the next evolution of health information exchange to support more patient-centric care model by supporting whole person care. The HIE in Michigan started in those inner rings, so the traditional, what we consider the traditional types of care settings, hospitals, doctors' offices, payers, et cetera. And that's what the current HIE supports mainly in its data exchange. However, the HDU aims to expand data sharing to other services like emergency medical services, foster care, schools, and other community-type organizations your residents are seeking care in. The data also that it will be flowing through the network as a health data utility can be used to help monitor and analyze population health and public health trends, so we can see different trends within our state, and identify health disparities, and monitor impacts of interventions and policies over time. We will have a source of data to be able to see that from a statewide perspective. The state designated health data utility will prioritize the interoperability or the integration of social, physical, and behavioral health by creating data standards based on national, state, and local regulations to ensure our care providers have the right data for the right person at the right point of care, wherever that resident seeks care. An HDU will enable our stakeholders the data needed to promote health equity, social care services for their patients, for their members, and provide near real-time data needed to modernize our public health infrastructure throughout the state and support our communities. By ensuring data is available at the place residents wish to seek care, the HDU aims to inform shared decision-making and supports improved whole person care through enhanced care coordination. And by using more robust data to concentrate on prevention and early interventions, an HDU can contribute significant cost savings by reducing duplicative testing and procedures associated with health conditions left untreated for long periods of time. House Bill 5284 establishes the funding for statewide health data utility in the Insurance Provider Assessment Act. We strongly believe the HDU will be a valuable tool for its stakeholders and meet the requirements set forth in the IPAA. One of the goals of the HDU is to increase the amount of health and social-related stakeholders to its infrastructure. So the more stakeholders, the more data. This will equate to, obviously, an increase of data flowing through the network, and the HDU will be responsible to make sure that data is maintained, standardized, and secure and private according to the laws and policies that protect the various amounts of data it receives. Again, the HDU model supports state and federal level initiatives such as the Michigan Health Information Technologies Bridge to Better Health Report, their 5-year strategy to move and enhance health information technology in the state of Michigan. It also supports the 21st Century Cures Act at the federal level, which many of our stakeholders are beholden to follow. It supports many care models that we are seeing within the healthcare ecosystem that aim to bridge the gap between physical, behavioral, and social care. And the health data utility is a tool for our public health systems at the local and state level to access more real-time data to assist with their program efforts. This is not a system that's going to replace the public health systems that the department and the local governments use. This is a tool to help provide more real-time access to data that will strengthen their programs. Michigan's existing health information exchange infrastructure positions us as an early advocate for HDU implementation and places us at the forefront nationally for digital health strategy in Michigan. And speaking of nationally, Isabel, are you with us?
Dr. Isabel, are you on the Zoom? I think we have
I am
to.
here.
Okay,
Yes,
perfect.
can you all hear me?
1 second. I think we have to take the presentation down and then get her up. So 1 second so we can see you. We're switching gears. Welcome to Health Policy. Begin whenever you're ready.
Okay, great. Can you all hear me?
Yes, we can. Thank you.
Thank you. Good afternoon, Chair Rogers and members of the committee. Thank you for allowing me to join you remotely. I'll be talking about what's going on across the nation. Nationwide, health data utility is what health information exchanges are evolving towards. Essentially, health data utility is the evolution of health information exchange, and funding across the U.S. ranges between $20 and $50 million. Here, what you might see, I don't know if you can still see the screen, or if not, I'm on page 14 in your packet there. We have states that are in dark blue, representing those with HDU legislation that has either been introduced or passed. You can see Nebraska there. Nebraska has a statewide HIE with over $50 million in appropriation and has for over a decade. Missouri and Maryland, mentioned by Rep. Rogers. Missouri has 4 HIEs in its state and has passed HDU legislation in 2022, securing an annual $50 million appropriation. Maryland is the state designated HIE and is now operating as an HDU with legislation passed in 2022 and has also secured $50 million in funding. The states in purple represent states that have either indicated they will pursue or are currently pursuing HDU status through legislation and funding. Oregon does not have a state designated HIE and has not to date produced legislation as of now. California has multiple HIEs. None are state designated. Total funding for California is under $50 million. Colorado and Arizona do not have state designated HIEs, but rather they are managed by one HIE company, each with $20 million statewide HIE funding. And New York has multiple HIEs with $200 million in state funds. The page after this is just it's a table that depicts the information I just mentioned in a different format for quick reference and visualization. Moving on to security. Privacy and security of health data exchange are vital to protect patients' sensitive information from unauthorized access, ensuring confidentiality, trust, and compliance with regulations like HIPAA, ultimately safeguarding individuals' privacy rights and preventing misuse or breaches of personal health data. MyHIN has always remained security aware and is at the forefront of cybersecurity in Michigan. We've been heavily involved in Michigan Healthcare Cybersecurity Council. This council is a trusted community of experienced cybersecurity practitioners and leaders who support and advise healthcare organizations and stakeholders so that relevant information and practices mutually benefit our collective security. And MyHIN ensures a strong legal chain of trust. Evolving from a health information exchange to a health data utility status will enable health data utility to build off of the HIEs or health information exchanges existing legal and technical infrastructure. This infrastructure is protected under high trust and direct trust, both global leaders in cybersecurity assurance. These accreditations require rigorous review and validation, which demonstrates MyHIN's capabilities in establishing trust, promoting interoperability, policy adherence, ensuring uniform security compliance, risk mitigation of PHI exchange, HIPAA and privacy compliance, business process oversight, and best practices. In addition to the Direct Trust Health Information Service Provider accreditation, MyHIN has several other Direct Trust accreditations. As stakeholders and consumers of healthcare, we know that security and cyber resiliency are critical. Healthcare data is not immune to threats of security breaches. When one of our participants experiences a cybersecurity incident, MyHIN swiftly and immediately disallows bidirectional data exchange. An example of how we strive to create a safe and secure data exchange is through our accreditation and operations, and by requiring every employee at MyHIN to undergo cybersecurity, privacy, and HIPAA training annually. Choosing a health information exchange as the gatekeeper of health data utility is ideal because HREs are designed to facilitate secure, efficient, and standardized sharing of health data across different entities. This ensures improved patient care coordination, enhanced data security, and better health outcomes while maintaining strict data privacy and security standards. We take security and privacy very seriously regarding data, the data that the healthcare community and residents of Michigan entrust with us. And with that, I'll turn it back over to you. Thank you.
Thank you so much. Last up, we have Dr. Bonsack with Trinity Health. And if you could keep your remarks to about 3 to 4 minutes, we do have a lot of questions. Welcome to Health Policy.
Thank you, Madam Chair, members of the committee. I guess by Marty's metaphor, if that's the plumbing, I guess that makes him a plumber and I'm a faucet. So glad to be here and talk to you today. So I first learned about health information exchanges during my University of Michigan public health degree. I learned about the HIA in the Upper Peninsula, which connected hospitals from Manistee to Marquette, Ironwood to the Sioux. And it was a fascinating exercise in learning how we could connect hospitals across the region. Since that time, I've been a strong champion for shared, secure messaging for all of Michigan, inspiring me to join the MyHIN board, where I now serve as a fiduciary member. Prior to my master's in public health, I'd experienced firsthand the real-time exchange of data for me as a flight surgeon with the United States Air Force. I was able to access active duty records across the entire world, continental United States, Europe, and many locations in Southwest Asia, including Kuwait, Afghanistan, and Iraq. Accessible and actionable information was critical to the health, safety, and well-being of the soldiers, airmen, sailors, and Marines we served. I then transitioned to civilian practice 13 years ago. I experienced so many silos of information, exactly, Chairman, that you've experienced as well. It compromised my ability to practice safe medicine in an effective manner. I've continued to support and amplify those lessons learned that I have from my academic and military careers, where I now serve as a population health management medical director for a major healthcare system. This health data utility will take Michigan's HIE to the next level so we can better coordinate care between stakeholders, track current and emerging public health concerns, and reduce waste and redundancy in the various medical delivery models. In addition, we'll be building on an existing secure and comprehensive network, enabling providers, epidemiologists, and health informaticists to improve the quality of care, enhance a holistic patient experience, support the care team, contain costs, and advance health equity in our communities. I'd strongly urge you to support these two bills to advance the digital infrastructure we have for Michiganders, your constituents, and my patients. Thanks for the opportunity.
Thank you. And if you want to just stay right there, because we may have some technical questions, as well as Marty and Kim. So first
Plumber
up,
back here.
first up, we have Representative Filler, and then Reingans.
Yeah, this is really complex, and obviously I'm not an expert in MyHim in any way. Seems to be some sort of like a info aggregator that then kicks out information to hospitals and everybody so that they can make decisions about the care they're giving. And what you're trying to do is supercharge MyHim so we can make even more sort of big policy decisions in the state of Michigan. Is that a misread of what you're doing? Okay, can I have just a little bit more on that?
Certainly. So if I understand your concern, please forgive me if I don't.
No concern, really. Just
Okay,
you have
clarity.
MyHim right now.
Thank you.
Which people are generally supportive of as information gathering. This will take MyHim and include a bunch of new information and new accessibility so that people can take that and then provide better care or
Yeah.
more detail.
Thank you, Representative, for rephrasing the question. So if I can take a stab, and then I'm going to refer to the other experts. But there is nowhere in these bills that talk about MyHIN specifically. So the idea would be in the latest version to have DTMB do some kind of RFP. And so MyHIN does this right now. They're talking about what they do right now. And yes, we're talking about adding some layers and making the whole system a more robust HDU. I'm going to now defer to them, but just to be clear, there is no place in this bill that specifies who that entity would be.
Yes, and it's not, it's as Representative Rogers said, it's adding additional layers. We are understanding that residents, especially due to the pandemic, et cetera, are seeking care closer to home. They're not seeking care in traditional hospital provider offices. You see folks getting immunization shots at the pharmacy. You see school-based clinics, in schools where students are receiving care. And so really, and then you have community-based organizations that are really addressing the social needs of our residents in Michigan. And healthcare only really, the traditional healthcare really only targets about 20% of a person's whole well-being. 80% of a person's health is about their social factors. And really that's where the community is addressing social determinants of health and how that affects a resident's health. And so really what one of the main pivots a health information exchange is taking is adding on those additional layers to make sure that the people on the social side know who is treating and what's treating, and they can coordinate care between those settings more seamlessly with the information that they can see. Again, as Marty mentioned earlier, we have a strong legal infrastructure. We are governed by HIPAA, and we need to make sure as the health data utility, when we add more sectors in, we need to address those laws and those different regulations that address those data types. It's not going to be a faucet where it turns on automatically. That's what the responsibility of health data utility is understanding those laws and regulations of those different types of data that's outside of HIPAA from those different care settings to make sure it can be integrated and shared in the secure and private manner.
So does it work on top of MyHim or with MyHim or separate from MyHim?
A health data utility?
Yes.
I would like to hope that because of the investment that has happened since the Granholm administration, MyHIN wins the RFP and we build upon it. All right? But I mean, we do have to follow the rules of engagement, which we plan to do.
Thank you. Representative Reingans, and then Glanville.
Thank you, Madam Chair. Thank you for being here today. I'm really excited to hear about this. In one of my previous lives, I worked at a health policy research center in Ann Arbor that worked closely with MyHIN to establish some data sharing and coordinated care management between physical health organizations, mental health organizations, and social service organizations, none of which used the same electronic health record. And so we had a lot of discussions on how to jointly manage patients and then I, as a public health person, was so excited to be able to aggregate the social screening that we did and see at the community level what kind of actions could we take through maybe county government or other areas to help address social needs as were identified by the universal social needs screening. So I really appreciate the need for this and can see how it will be used. I just want to clarify, Dr. Bonsack, that you are saying your experience in the VA, which is an integrated financing and delivery system, that is not what we're talking about. Just to clarify for folks, we are not talking about integrating our financing in our delivery system. We're not talking about having one health record for the whole state of Michigan. We're not talking about a health record that is accessible to every social service organization that would be the same as the one used by the CMHs, that would be the same as the health record used by hospitals. Each of those private or public entities would maintain their own health records. So my question to you, I have two questions, is about the integration. The entity that becomes the data utility through the RFP process is just going to be able to make sure that every place that uses data in Michigan has the same form fields, for example, so that the name form field from the CMH can talk to the name form field from the hospital, right? And it would go through the pipes of the data utility.
Yep. Part of the HIE, one of the critical infrastructures of an HIE is identity management. So we have to make sure that we understand who is who. Each system uses a different medical record number, right? And so in order to seamlessly share that information between different systems, some neutral body in the center needs to understand all those medical records numbers that the patients are assigned, and then make sure it's routed appropriately, because that's key and cornerstone to making sure the right data for the right person is at the right point of care.
And that's the common key that's mentioned in your
Correct.
timeline.
Thank you,
from a few
Representative
years
Reingans. Can you go to your next question? We just have a lot of questions and 10 minutes left.
The question I have is, since the funds would be assessed on health plans, including public health plans, how is the governance of the funds going to be happening in a public way to be accountable to the public funders?
Do you want to take that question? Rep. Vanderwall?
Certainly. The funding model is what you're asking is what this is going to do, correct? The governance and accountability. The department is going to oversee that, and that's exactly what this funding will provide us, to make sure that we monitor everything that goes into the pipeline. I love how we become plumbers all of a sudden today, but everything that gets through and is in the data complex, it's going to be monitored and analyzed, and that data that comes back out of there will help us form the opportunities for direct and better care. The dollars, correct, but those dollars, that's what those dollars are going to be for. We still have to manage it. We still have to build the infrastructure system. You just can't, it doesn't just start. So that's what those dollars are for.
Thank you. Representative Glanville and Fitzgerald?
Thank you, Madam Chair, and thank you all for being here today. I'm very excited about this. I see how we've kind of been doing this in an analog sense for a number of years. If you take an organization like Meals on Wheels, for example, whose volunteers visit many people once a week and report back if there's any issues and things, and they often follow up on those things. But of course, that may not ever get shared with healthcare workers or family members or whoever. So I really appreciate how we're bringing this together, and also just want to note, I think a lot of people have your health data can be mined also just from your Google searches, right? If we're ever on WebMD, they might know a lot more about our symptoms in healthcare than our doctors do. But that said, I'm curious, and I know you probably don't have the details on this, but can you just give me an example of how a CBO, knowing that CBOs, often operate on volunteers and this sort of thing, what does that sort of privacy piece look like on that end as people are collecting and entering that data on the CBO side, or if we're dealing with like a volunteer, institution?
I can start. Yes, we're actually just starting to have great discussions with CBOs.
Can you, for the benefit of everyone,
Oh,
say
I'm
what
sorry,
a
community-based organizations. So we are actually starting some great conversation with community-based organizations, also working with, it's more of like hubs or community health innovation regions that are in the state of Michigan, which are hubs that connect many community-based organizations together. So we're having great conversations. We believe that when we're learning their processes, however, there's consent in place when a person is referred to a community-based organization. Within the paperwork, our understanding there's a consent in place to help, but we have not, that's kind of part of where we need to go with a health data utility, is understanding the proper legal and technical way we can share in a private manner between those types of settings in a traditional HIPAA-run health information exchange, if that makes sense.
It does, thank you.
Thank you. Representative Fitzgerald.
Thank you so much, Madam Chair. Thank you for your presentation today. My background is in property and casualty insurance and worked heavily with cybersecurity products with companies of ranging sizes. Clearly, that's of a concern here because we spent a few slides here kind of addressing the security needs. And one of the things that gives me a lot of hesitation is, this slide right here where you kind of show the expanding future of healthcare, right? Because yes, this is faucets and piping, but there's also intakes, and there are a lot of storm drains and other entry points that go in here. And while everyone likes to think of front doors and back doors, but there's side doors, windows, and chimneys for people to slide into. My point is that if this is the electronic transfer of data, that this data is going to touch MyHIN. It's still going to transfer through the piping. My concern is that even if we've only been open since 2017, right, in this format, that my curiosity is, do you know how many times MyHIN is trying to be accessed by a nefarious, actor who's trying to access the information within MyHIN? And there are times where these breaches are not known because they lie dormant for years before they are exposed because they've been waiting for the aggregated data to become available to them. And these are all liabilities in my mind in this network. So can you explain a little bit about that?
So we are monitored 24/7, the environment. We use AWS Health Share.
I'm so sorry, but in the interest of time, his question was specifically.
I can't speak to the detail, but I can get that back to you if you will allow, because the cybersecurity team is not here to answer the detail of the question that you asked.
I'd like to speak with them, yeah. So thank you very much.
Thank you. Next up, we have Representative Thompson and then Farhat.
Thank you, Madam Chair. I know we're short for time, so I'm going to go really quick. So the incident that was discussed about the medication that was missed going in from a hospital into a skilled nursing facility, or assisted living to skilled nursing facility, what in this process would change that transcription of the medication? So I'm at an assisted living facility. My family member has a fall. They get sent to a skilled nursing facility. What changes between now and this being implemented would have ensured that that medication was transcribed?
So I'll take that one since it was my personal story. Oftentimes, these are being done verbally, being given verbal report. And so that verbal report is there's a lot of mistakes that often happen in a verbal exchange versus something electronic going through a pipeline.
Well, that's what I'm trying to understand, how it changes it, because I have taken verbal report on medication. That's what we do when we do patient admissions, and we have to transcribe all the medications, the dosage, and we report to the doctor, yes, these medications are coming with this patient to be administered in the same manner. Is that correct? And the doctor has to say correct before the nurse signs off on it to put those into pharmacy.
But there's evidence that when it's in writing versus verbal, there is evidence.
So now we wouldn't be calling the doctor to verify the medications.
I'd say every hospital is going to have its own, or every facility is going to have its own procedures. It's not prohibiting that.
Okay, another thing. What if I have my relationship with my doctor and the things that are in my medical record with my physician, or my child's medical record with my physician? What if I don't want them being shared with everybody in the circle? How do I stop that?
We're working through a process, e-consent, so that it can be stopped, so that you as a patient or a consumer of healthcare will be able to elect what to be a part of and what not to be a part of. It's at your discretion.
So there would be like check boxes, like I'm okay with the health department, the state,
We're going to have to go
the
that
school.
granular. Yes, ma'am.
Okay. And then
Thank
one
you.
last
And the next question, no, I'm sorry.
does this have to
I
do
am
with
sorry. We are
immunizations?
having order in this.
I said
No,
I'd go
we
really
are going
quickly.
on.
You asked.
We are going on to the next person, Representative Farhat.
Thank you, Madam Chair. I guess my question centers on two things, and I actually share Representative Fitzgerald's concerns around cybersecurity. And so I'd love to hear about a track record of sorts that you folks have had in that space and preserving patient data and patient records. I think that's very important. Secondarily, I'm wondering, as I'm reviewing our policy sheet here, we're seeing that the department here, DHHS, is actually, it does not support this. They're in opposition, is that correct? On our policy sheet, that's what it says. I'm curious if the department has specific feedback as to why that is.
So we are going to read in the cards probably next time, and we will upload them to the website. This is the first of, we will have another hearing on this. It's a very complicated topic. There will be ample time to get everyone's questions answered at another time. I am sorry that we are up against a time frame, and I do appreciate everyone's questions. I appreciate everyone testifying today as well, and there being no further business before the committee will stand adjourned. We'll get to you next time.